Welcome to the February 2020 edition of QI Connect, our first of 2020. QI Connect provides an opportunity for colleagues across health and social care to learn from international leaders in the fields of improvement, innovation and integration. So welcome. I'm now going to pass you over to Jennifer, who will tell you a little bit more about the session and the technology. Good afternoon, Jennifer.
Thanks, Ruth, and good afternoon to all of our QI Connectors joining us on the session today. I can see quite a few hellos in the chat box as we speak, which is lovely. So I just have a couple of quick housekeeping slides to get started. If you can please use the chat function that you see on the right-hand side of your screen to communicate, and I'll talk you through this in just a moment. We do want this to be a really interactive session. If you are having any technical difficulties, such as not being able to hear the presenter speak, or if you keep losing connection, then please message the event manager using the chat function or by calling *0 on your... There you go, that's the first technical issue on. If you just press *0 on your telephone keypad. So as I mentioned, these sessions are designed to be an interactive learning experience. So we do encourage you to use the chat function to share any questions, comments or ideas throughout the talk. And there will be an opportunity for a Q&A at the end of the session. Just to note that we will also be sharing hyperlinks within the chat function to any resources mentioned by our speaker today, and we'll be circulating those to you for information afterwards. So we did promise that today's session would be fun and interactive. We're keen to find out where you're joining us from today. If you could please select the annotation tool that's circled in red on your screen here. And then click on the arrow icon, also circled in red. And then get ready. And then if you could please click on the map just to show where you're joining us from. Sometimes there can be a slight delay with people joining from overseas, so we'll just give a little bit of time. So hi Nancy, we'll see the UK just kind of disappear here.
And Jackie from London, hi. Emma from Belfast, I think, hi.
Hi Fran, hi Rachel. There's a few HIS colleagues there as well. So I'm now going to just pass you over, so welcome to everyone. I'm now going to just pass you over to Ruth, who's just going to take you through a little bit more about QI Connect.
Thank you.
Well done.
Thank you, Jennifer. So my name is Ruth Glasper. I'm Director of Improvement with Healthcare Improvement Scotland, and I'm your chair today. Regular QI Connectors will know that we run a competition on each session. So get ready. The first person to click on the flag for Uganda will win a prize.
Close, there's a few. Oh,
Chris. Well done. Congratulations to Chris Webber. Not quite got all of the name there. You win the QI Connect mug, so we will make arrangements to get that sent over to you. So as of November 2019, I'm delighted to report that we have over 1,200 organisations who join. Some watch live, others watch the WebEx afterwards. We also have representatives from every single Scottish board, and we now have over 89 colleges and universities from around the world joining in. And just to remind you, the rest of our back catalogue is available for you to watch and enjoy on our website. We are also, the QI Connect series is now featured as an approved resource within ISQA's fellowship programme. And I also just want to give a call out to the Health Foundation and to confirm our partnership with Q, an initiative that is delivered by the Health Foundation and also co-funded by NHS Improvement. The QI Connect team, just to say thank you to all of these individuals who helped this to run so smoothly, and also to introduce Lynn Clark, who is our guest questioner today, and she'll be asking the first question at the end of the WebEx. Finally, to remind you, please remember to tweet as you learn today. There's our hashtag, and do also follow us at HisQI Connect. So I am delighted today to introduce Trish Greenhalgh, who is a Professor of Primary Healthcare Sciences and Fellow of Green Templeton College at the University of Oxford. As well as being a practicing GP, she is also the author of over 400 peer-reviewed publications and 16 textbooks, including the much acclaimed How to Implement Evidence-Based Medicine in Healthcare, which created quite a stir in 2017 when it was released and was one of those must-read books around the world of improvement. So if you've not read it, do get yourself a copy. She is a fellow of multiple colleges and faculties, too many to individually mention, and she was also awarded the OBE in 2001 for her services to medicine. We're delighted that she's joining us today to talk about one of her passions, implementing technology-based innovations in healthcare. The fact that she is on the line today also means that the part of a World War II bomb that her husband brought home yesterday after clearing out his parents' garage clearly didn't explode in her kitchen, which I am relieved about. And if you want to know more about that, do check her out on Twitter. Tricia, over to you.
Oh, thanks very much. Yeah, what a great introduction. I have to say I'm no longer a practicing GP. My academic job has rather taken over, so I hope things that I say today won't be too out of date clinically. I do still do what we call ethnography, where I watch other clinicians doing their work. So the title of the talk I'm going to give today, and I have to say we've got a slight technical problem in that I can't see the webinar screen that most of you can see, so we're doing this slightly remotely. I've got my own slides here, and the title I've got in front of me, I hope you do too, is eHealth Infrastructure, Why We Need to Be Interested in Boring Things. And I've got really interested in boring things recently as I've been doing research in the NHS and other healthcare organisations, and I've actually spent quite a lot of time in Scotland recently. I spent most of last week in Scotland. I had a very warm welcome, but I'm not going to be telling you too many empirical findings from our Scottish study because that wouldn't be diplomatic, because we're funded by the Scottish Government to look at the Attend Anywhere work, and we haven't actually given our report into them. So I'm going to be telling you about other stuff today. So if I could just have the second slide, please. And you should be seeing a picture of a paper that my team produced. The names of all those other people are quite important because it's not just me doing this work, it's a whole team, mostly funded by the Wellcome Trust at the moment. And we produced a paper which was published just at the end of December called Infrastructure Revisited, an ethnographic case study of how health information infrastructure shapes and constrains technological innovation. So a nice boring title because it's a boring subject, and I'm now going to explain to you what infrastructure is and why it's so important. So third slide, please. Now, Susan Lee Starr, who's a sort of anthropologist of material things, sadly is no longer with us, but 20 years ago she was writing lots of papers about infrastructure, and she defined it as what other things run on. And she set some pretty good principles as to how to study what other things run on. You sort of think of infrastructure as the transport networks and the sewers and the pipes and things like that. Information infrastructure, it's more about the servers and the wires, but many other things as well. And you can see in the bottom right of this slide that Susan Lee Starr set up a society called the Society of People Interested in Boring Things. Next slide, please. Now, boring things in relation to information infrastructure are the things that you don't normally study. They're things like classification schemes, wires, plugs, adapters. If you go off to another country, you have to work out which adapter to have, technical specifications, regulations, standards, barcodes, QR codes, all that kind of thing. And in general, when we do research, we sort of background those things. But the study of infrastructure requires us to foreground them, because so often these are what make or break a technology project. Next slide. Now, one of the pieces of work we looked at in our Wellcome Trust program of work was wearable technologies for children with epilepsy. And you can see that if you just look at the top picture there, it's a rather beautiful technology. The little girl's very happy to wear it. It's been nicely co-designed with the patient. But the reason why this stuff hasn't really become mainstreamed in the NHS is that in order for it to work properly, it's got to interface with all that messy stuff in the bottom of the slide, the patchworked, clunky, heavily regulated, slow-to-change infrastructure. And many of you will be sitting at perhaps an NHS computer, which is rather more out of date than you might want it to be. And there are all sorts of issues with infrastructure, what you're allowed to download. I'll tell you a bit more about that on the next slide, actually. Can we move on to slide 6? So, in our paper that I talked to you about at the beginning, we drew on Star's work. So we sort of bring her work 20 years forward, and there's quite a bit that's happened in between. But the reason why we called it Infrastructure Revisited was that we were drawing directly on the original work that this very impressive researcher had done. And she had presented 9 defining features of infrastructure, but we sort of collapsed some of those and made them into 5 defining features of information infrastructure. And the first is that it's a material scaffolding, backgrounded when working, but it becomes visible when it breaks down. We don't notice it until it stops working, and then, my goodness, we notice it. Secondly, that it is embedded in systems. It's relational and it's emergent, and I'll explain what I mean by that in another slide. Thirdly, it is collectively learned, known and practiced through shared routines and distributed actions. Fourthly, that it's both patchworked, in other words, it's built and fixed incrementally, and also it's path dependent, in other words, it's shaped and constrained by purchases made and contracts signed in the past. And fifthly, it's institutionally supported and sustained through things like standards, norms, and codes of practice. So next slide, please. So here's the first defining feature, this idea that it's in the background most of the time, but it becomes visible on breakdown. And there's been quite a bit of work since Susan Lee Starr's work around maintenance and repair. And I love this quote from Jackson and colleagues. What world does contemporary information technology inhabit? Is it the imaginary 19th century world of progress and advance, novelty and invention, open frontiers and endless development? Or is it the 21st century world of risk and uncertainty, growth and decay, and fragmentation, dissolution, and breakdown? In other words, what they're saying here is that things breaking down are actually part of reality, and the more complex the information infrastructure, the more it is just a part of life that things are going to break down, they're going to need to be fixed, there's going to need to be an IT department who are going to give you a ticket to help, put you in the queue for a repair. And that kind of thing we should actually be incorporating into our plans and our analysis, because it's never going to get any easier. We're never going to get rid of it because actually we live in a more complex world. Next slide. So the second feature of infrastructure is that it is, and I quote Starr, it is sunk into other structures, and it's also inside of other structures and social arrangements and technologies. So it's hard to tell when one piece of infrastructure ends and another begins. And it is also the case that the relationships between professionals, between organizations, are part of infrastructure. It's not just the material infrastructure, it's also the networks of people and the links between organizations. So that's pretty important. Next slide. So the third defining feature is that it's collectively learned and it's collectively enacted through shared routines, particularly. Very little healthcare these days happens from the isolated practitioner. Mostly it's either a team doing it together, as in the picture, this is an operation obviously, or it's one member of a team putting something on the electronic record and then another member of the team entering a piece of information on the same record. Now, we are quite interested in what we're calling organizational routines, which has been defined as a repetitive pattern of interdependent action involving multiple actors. And we go about our work in the healthcare setting by following routines. But we don't follow them mindlessly. We follow them quite creatively, actually. And Martha Feldman, who's the world expert on organizational routines, said routines are performed by people who think and feel and care. Their reactions are situated in institutional, organizational, and personal context. In other words, we do things in a particular way because of who we are and because of the sort of organizational logics and patterns of doing things. So any technology, of course, that cuts across an existing routine is going to be particularly hard to implement. But routines are part of infrastructure. Next slide. I've talked about patchwork and path dependency. This picture here is actually from the Bletchley Park Computer Museum. It's a very old-fashioned computer, and I've deliberately picked that. But I've also given you a very old-fashioned looking service-level agreement, because you will find that when you try to implement something new, you may well find that there's some kind of legal agreement, which means that you can't just go off and get the supplier that you'd like. And Ole Hanseth, who's a Norwegian researcher of infrastructure, he defines it as a layered patchwork of components and associated routines which emerge historically. It's very, very hard in a particular setting to kick against the path dependency of history. Next slide. I'm on slide 11, I hope you all are. The last feature is this institutional dimension of infrastructure. March and Olson define institutions as things which reflect the routine way in which people do what they're supposed to do. So, for example, professional standards of confidentiality and safety, but also technical standards. These are built into infrastructure, and this is why it's particularly difficult to introduce a technical digital innovation at work as opposed to at home. You are just bound by a lot of institutional commitments and rules and regulations. So here's the, next slide. Just to give you that slide again, the 5 defining features of health information infrastructure. Now, these have huge implications for how easy it's going to be to introduce technologies. So next slide, please. Slide 13. I'm going to tell you very briefly about a case study of spreading and scaling up video consultations in England and in the UK, as in, for example, Norway and many other countries, including Scotland. The uptake of video consultations is quite slow and it's also patchy. And I do know the Scottish data because I can tell you that 62% of all your video consultations happen in 2 health boards, and the other, however many there are, 12, 13 health boards account for the other 38%. I've got a little paper here, which you can see, adoption of routine telemedicine in Norwegian hospitals, and actually you can see an awful lot of little spots on that graph are still right at the bottom. In other words, hardly any organisations have actually got going at all, and then there are one or two organisations that are doing very well. But that is very classic, and it's not far off the Scottish experience. I think there's a few more black blobs in the middle of the graph in the Scottish experience, but certainly in England that really reflects what's going on across the country. So why is that? Okay, next slide. So if you look at systematic reviews, I've given you one here from Australia, another one's covering, I think, most countries. And since 2000, there have been many, many systematic reviews. They show that video consultations are popular with patients. They're safe, so long as the patient has been deemed clinically appropriate for the particular thing they want to consult for. So why is hardly anyone connecting via video? Well, the history of video services in every country is of some small, local proof-of-concept projects that don't spread very well and are rarely sustained. I hope when I finish my talk, someone from Scotland is going to come along and say, no, we're doing better than that. And I think you probably are, actually, which is why I'm quite interested in Scotland. But this isn't far wrong for most countries. So what did we do when we were looking at the introduction of video consultations down in London, actually? We followed these principles, which were set out by Susan Lee Starr more than 20 years ago. Sorry, I'm on slide 15 at the moment. I think I forgot to tell you to go on. So the principles are, firstly, to focus on boring things. The wires and the plugs and the regulations and other things which I'm going to tell you about. To tease out master narratives. What are the overarching discourses, the overarching things people are talking about that shape decision? Thirdly, apply infrastructural inversion. In other words, bring to the foreground things that are normally in the background, and vice versa. In other words, don't study the obvious things. Fourthly, make invisible work visible. Look at the work people have to do in order to make whatever it is work. And we've been doing a lot of very detailed study of invisible work. And finally, study paradoxes and nonlinear effect. Why adding, for example, one keystroke just then makes everything unworkable? You'd think it wouldn't, but it really does. Okay, next slide, which should be on 16 now. So what we did down in London in Barts Health Trust, actually, which is huge, I think it's the biggest acute trust in the UK. It involves many different hospitals, some of which are just outside London, some of which are right in the middle of London. And we hung out for several years, actually. We did over 100 interviews. We watched things happening in various departments. We looked at documents, and we also videotaped consultations both at the patient's house and in clinic. So that we had two researchers taping both ends, and then we joined those together to analyse them. And we analysed our data, and we pulled it all together in what we call a narrative synthesis. That just means we told a rich, in-depth story. So next slide, please. This paragraph is the first paragraph of our results section, and we said then the data set was characterized by a striking prominence of boring things, all sorts of things, protocols, rules and regulations. The effort to spread video consultations right across this very large trust was often stalled or distorted by things that were so mundane that we initially hardly noticed them. In the early months of our research, we unconsciously backgrounded these boring things as our research gaze was drawn to the more conventional subjects of ethnographic observation, the things that people were doing. But as the study unfolded, we recognized a recurring pattern that human actors, that people often found themselves unable to act in a way that would have helped implement and spread the video consultation model. It's when we asked ourselves, hang on, why can't they do what they want to do? And then we found all sorts of interesting, boring things, shall we say. Next slide. So Here's an example, and this is now quite old data. You can see that it starts in 2009, so they've been going for about 11 years in BARTS. So if you look at just the left-hand panel, first of all, this is all about which platform they were selecting to run the video consultations from. And initially they decided they would use Adobe Connect. Now, why did they make that choice? Adobe Connect is a video conferencing software, and the reason was that the funder, who was NHS England, a national policy maker, had already shaken hands with the Adobe commercial supplier and bought licenses and effectively imposed that decision on NHS trusts in England and said, well, look, this is the one we're going with, and you can have it for free, but if you buy any other one, you've got to pay for it. So BARTS, like a lot of others, signed up. It wasn't a piece of software that anyone was familiar with. It was very hard to set up. And it was also professionally quite awkward. The doctors said, well, you know, all the instructions assumed that there were speakers and listeners and there was a chair, and this came up on the software. And, of course, if you're a doctor trying to connect with a patient or a nurse connecting with a patient, the language was very awkward. But that was all the path dependency of that national policy decision. So after a few years, this hadn't worked very well. One of the consultants said, well, let's just use just plain old ordinary Skype. And the reason why that worked rather better was that it was free, everybody was familiar with it. This was being done in Newham, mainly, which is a part of London where there's very high minority ethnic group. About 63% of people in Newham are from a minority ethnic group, first or second generation immigrants. And what that meant was they were already using Skype to connect to their relatives abroad. So everyone was happy. It had what they called a casual connection logic. In other words, patients felt very happy, very empowered using it. They already used it to connect to family and friends. Now, of course, you might think, hang on a minute, Skype isn't really approved for use as an NHS tool. Too right it wasn't, and that was problematic. The IT department said, well, look, we're not doing this right across the trust, but we would install it as a favour, just for a demonstration study. So the very charming consultant diabetologist went along and charmed the IT department to just put it on the machines in the diabetes department just to see if things would work. But they were adamant that they didn't support Skype for hospital-wide use. Now, it wasn't that this was against information governance rules, but it was just that the information governance rules simply didn't exist at the time for using Skype on NHS computers. There were no service level agreements, there were no protocols, nobody knew how to install it because there wasn't a protocol to follow. Nevertheless, the diabetes clinic installed it and started using it and had some very successful consultations through it. But then what happened, and here's an example of the patchwork nature of infrastructure, the hospital decided to change to what they call VDIs, virtual desktop infrastructure. And what that means is that on each machine in the outpatient department, for example, all there was really was a terminal. You didn't have much on your desktop because what you had was an account which was kept on a central server and you could log on. The problem with the virtual desktop infrastructure was it produced a major technical conflict with Skype. So suddenly you could open up Skype, but you could no longer see the people that you were supposed to be connecting to, which is a bit of a problem if you were a clinician wanting to run a clinic. But then what happened is they discovered a single desktop computer in the clinic, which was a legacy desktop, if you like. It somehow missed out on having this virtual desktop infrastructure. So it was rather like that one in the picture that I showed you, very old-fashioned, and everyone kept quiet about it. But that was where the one clinician who was still running these video consultations managed to go in every week as much as she possibly could. Sometimes someone else was in that room, which didn't go down too well. Eventually, the IT department produced this very elaborate workaround on the VDI of this doctor and set up really a test account. And they discovered that if they set up just a test account, they could run Skype. So it was one big workaround. But this doctor, quite rightly, I think, wasn't confident that in this fix. It didn't seem like the sort of thing that you could do right across the trust. And so she decided to resist scale up. And not a lot has happened in that particular service since. They are now, you'll be glad to hear, testing out Attend Anywhere, but it's still only running in one or two services on a sort of demonstration level. So there are a lot of boring things we're accounting for this very slow progress. Can I have the next slide, please? So here's just another example of how the path dependencies play out very differently in different sites. Now, this actually, Hospital B, is a hospital in Oxford, and a previous purchasing decision here had included Skype and Skype for Business as part of a wider package. So whereas at Barts, you couldn't run Skype because they said, well, we don't know how to do it. In Oxford, no, that was fine. You could have Skype, and you could also have Skype for Business because that was now part of NHS Mail. So this is much later in time. You can see it didn't start till 2018. Patients could use the consumer version of Skype to link with this. So that all sounded great. Unfortunately, there was the same problem with the VDI. It conflicted with Skype, and so the doctor, who I think was an orthopedic surgeon, went and just bought a laptop and had enough with the sort of network system in the hospital, so just bought a dedicated laptop to run Skype for Business. But the use of the laptop required information governance approvals and had to use a data protection impact assessment tool. You can imagine the kind of form filling that this poor chap was having to go through and then wait for a committee to decide on it. Finally, all the approvals were in place. The doctor tried to use the laptop, but then couldn't get past the login page. And the reason for that was that the Skype for Business within NHS Mail is configured only for talking to people inside your own organisation. The problem was that this chap wanted to link with the Barts Centre, who were supposed to be supporting him to run Skype for Business because it was all part of the same project. And for the external links, you had to buy an additional enterprise license, which wasn't part of NHS Mail. So in the end, one of the doctors simply bought their own laptop as opposed to from the NHS budget, and just asked the patients to use FaceTime, which was a workaround. But you can imagine that was never going to be something that was scalable. It was a senior doctor who said, "Well, I've had enough of this," and just did it. And I'm not even sure whether that is still going on. Okay, next slide. So, just to sum up what this example illustrates, the first is that bugs and breakdowns are a fact of life. Sometimes they can be fixed and sometimes they can't. Secondly, that the relational work and what we call the articulation work, the fiddling about, the tweaking of IT implementation is never ending. Not only is it never ending, it's totally necessary to make stuff happen. You're never going to be able to implement IT unless somebody's fiddling around, bordering on breaking the rules. Thirdly, that we need to study organizational routines and how they interrelate. Rather than just see it as a static technology that needs to be installed. We need to see how it works dynamically within routines. Fourthly, that local historical decisions, and in fact national historical decisions and legacy systems shape what is possible. And fifthly, that regulatory and professional standards may produce long delays and unsolvable conflicts. I rather suspect that many of you know that. Okay, next slide. So here's some principles for addressing infrastructural challenges when trying to scale up a technology. Firstly, pay attention to material things. Expect there to be bugs and breakdowns, and I would suggest that we prioritise basic dependability over advanced functionality. The simple stuff works best. Secondly, take a system and relational view of the technology as opposed to a sort of looking at the technology as an isolated tool or function. Ask what other technologies, what other people it needs to connect to. In what way does it have to be embedded? Thirdly, that technology-supported work is often cooperative. It's often embedded in routines, and these routines are embedded in other routines. So again, see the system as dynamic. Fourthly, innovate incrementally in small steps, paying attention to what both technological legacies and sociocultural legacies. In other words, the history of what has happened previously in particular settings. And finally, take note of standards. Ask where those standards have come from and whether there's flexibility to adapt them to local conditions. Next slide. So here's my summary. Infrastructure is about boring things. It's about wires, plugs, rules, standards, all sorts of things like that. Infrastructure is not just material. It's about things like roles, practices, routines, regulations. The best way to study infrastructure is by rich in-depth case studies, to study the not happening of an implementation effort, which very often is what all you've got is that it's not happening. Collect a lot of boring data over a long time. And finally, here's some principles of how to research infrastructure using ethnography, focus on boring things, foreground things that are normally backgrounded, and study paradoxes. So final slide is just to give you my Twitter handle and to thank you for your attention, thank the Wellcome Trust and also the MRC and NIHR for funding my work. I guess now I can take some questions.
A lot of what you've said is extremely relevant to our work in Scotland at the moment, as you'll know if you've been evaluating NHS near me, and we recognise many of the challenges that you've called out. Just to remind those listening, if you do have questions, please do submit them via the chat box. That's how we'll take questions. But before we go to open question time, we're now going to go over to Lynn Clark, who is the Senior eHealth Facilitator for NHS Highlands, who's our guest questioner. Lynn, over to you.
Good afternoon, everyone. Afternoon, Tricia. That's very interesting talk you gave there, rang a lot of bells. My question is, in the last quarter century, electronic data in primary and secondary care has amassed a plenty. So why doesn't this electronic data still not flow to the patient? Hospital inpatients sit in beds for 3 days wondering, has my scan been reported yet? GP patients referred to hospitals sit waiting for a letter to arrive in the post with a date. Patients can get more real-time information waiting for a bus at a bus stop than the time of their next healthcare event. How can eHealth do better than electronic appointment text reminders for patients?
Yeah, it's a great question, and I could spend the rest of this webinar telling you all about my mother-in-law and the experience she's had recently, but I won't because I think everyone's got a similar story. It is absolutely extraordinary, isn't it, that on the one hand we've got these amazing state-of-the-art technologies, and on the other it can be impossible to get through to the GP on the phone. It can be impossible to get one's own data. I myself had a bone density scan a few months ago, and I said, could I please have a copy of the scan to take away with me? And they said, no, it's information governance regulations, you can't take it away. I said, but it's my data, how can you throw information governance regulations? But there was no way they were going to let me take my data. So we've been there. I think the reason is that technologies are not simply tools. They are not simply containers for information. They are part of socio-technical networks, socio-technical systems. And as I said in my talk, one of the aspects of those is the institutional dimension of rules and regulations And you will often find that the reason why you can't access a piece of data is because of rules and regulations, not because it's technically impossible. But it's not just legal standards or information governance standards. So, for example, I've got the NHS app on my phone, and I can hit the app and use my thumbprint to get into it, and I can see a list of medication or that kind of thing. But what I can't see is my medical record, even though it is technically possible to see your medical record or bits of it through the NHS app. But what I do get is a little message which says your GP has not enabled your access to the NHS app. Now, why hasn't my GP done that? You could say my GP is just being awkward, but if you ask the GP, I bet what they'd say is, well, it's for professional reasons because we don't want patients getting distressed when they see what's on their medical record, and therefore, for good professional reasons, we're the experts, we know best, we are going to restrict their access. In other words, they are obeying what they believe to be a professional norm, which is that the doctor should be in charge of the information and should decide when and if that information gets passed to the patient. So I think your question makes a lot of sense if we move beyond the idea of technology as merely a container of information, merely a tool, and start to look at it as part of a very complex institutionalized system. Quite what we do about it is another matter. There are no simple solutions.
Thank you.
Thank you very much. So we've got the chat box is filling up with questions. The first one that came in was Nicholas Bamo, who works with NES in Scotland. And he highlights that you mentioned the example of Newham, where there were a large number of patients who are immigrants or second generation and therefore are using Skype or similar to connect with their family. He worked in a predominantly non-immigrant community. He says his patients are likely not to have used such a technology. Has there been any experience of supporting those types of patients in the uptake of technology, so individuals who aren't using it within their personal life?
Well, actually, you in Scotland have got some very interesting initiatives going on. I was out on the Outer Hebrides a few months ago and met some interesting people who are involved in the Empower initiative, which is an EU-funded initiative, mainly focused towards the over 65s, although they've stretched that rule a bit right out in remote parts of Scotland, where people are going into the homes of people living in geographically isolated areas and saying, come on, show us what technology you currently use. And they may have nothing. They may not even know what the internet is. They don't even have a mobile phone. And so they're starting from a very low base. But then what happens is that people work with those individuals to get them connected up. They actually make sure they've got a gas supply as well and things like that, electricity, that kind of infrastructure. But they're also doing a lot of work to introduce them to a technology and then ensure that they can use it. And use it not just for their health, but for different aspects of their life, for mail order shopping, that kind of thing. And, of course, this is quite slow work. It's quite labour-intensive. Someone who's 70 and has never used the internet is going to take a while to get going with it. But I was very encouraged because this is a high priority for Scotland, as I understand. A lot of work is getting put into it. And, of course, it aligns with a very, very important institutional value, which we picked up is very strong in Scotland, which is all about universal access to healthcare, reducing inequalities, making sure that the welfare state really does support the more vulnerable members and the more remote members of the community, as well as the low-hanging fruit. Does that make sense? So I think, you guys in Scotland are doing pretty well there. It's just that we had rather different challenges down in London.
Thank you. Claire Nash, who's a senior nurse at the University Hospital of North Midlands, is asking do you think that the push for greener healthcare will influence the uptake of technology at a faster rate?
Well, it's interesting. I mean, I was interviewing senior policymakers in Scotland last week, and that was exactly what they were saying, is that not only does video consultation services save a lot of time and a lot of travel, but it also ticks the climate emergency box. That people flying back and forth for medical appointments is a bit wasteful of the planet. Whether or not that is going to be a major driver is going to depend very much on, who's in power and what their priorities are. But I think we better swiftly move on from politics because otherwise I'm going to get into trouble.
Your Twitter account, Trish. I've got a question from Chantal Rexky from Canada. She seems like what she's saying is, it seems like there is often a rebel or an instance of someone going rogue or making their own workaround to get things started. Do you think we are always going to rely on this to initiate change?
To some extent, yes, and I'll tell you why. Is that by definition, innovation is breaking the rules, or at least it's inherently subversive, because organizational life is mundane and canonical, and we go into work and we follow the same patterns. We've got job descriptions, all that kind of thing. Dum-de-dum-de-dum. Someone comes along and says, let's do things differently. They are perhaps not breaking any official rules, but they're certainly breaking informal rules, because they're challenging the patterns and routines that happen. And actually, I'm quite interested in narrative as a research topic, that the innovator is quite often not just the rogue, the maverick, but also sometimes the underdog, the person who wasn't listened to, the person who perhaps has been excluded, person who is seen as a bit weird. And of course, one of the things that pushes innovation forward is those wonderful stories of how that person eventually succeeded and the chief executive had to eat humble pie and all that kind of thing. And if you look in, say, the Harvard Business Review, you have these wonderful stories of Hewlett and Packard starting in the back of a garage. Nobody really thought they were going to go very far, and then suddenly they're both billionaires, that kind of thing. So the innovator is very often, the underdog, the radical, whatever. Can we mainstream that? Yes, I think we can. And someone like Helen Bevan does this incredibly well, where she finds radical people, positive deviants, whatever, and then she showcases those and says, look, it's okay to act like this. It's actually pretty good to act like this. And that kind of narrative, so you shift the narrative to say, yeah, all right, we'll fall in with this. But then when you go back to the example of using Skype on a hospital computer, you think you've got to be pretty naughty in a hospital to start doing that, actually. I mean, nobody got into any major trouble, and at one level it all was kind of signed off. But, the institutional quicksand can be quite deep.
Thank you, indeed, yes. Catherine Carver is asking, how did you get a funder like WT excited about boring things? AI and big data are sexy, plugs less so.
Oh, yeah. Well, actually, the infrastructure stuff came up towards the end of our Wellcome grant. We were studying more generally the organisational challenges of assisted living technologies, actually. We just put in a grant for Wellcome to study the boring things, and they decided they weren't going to fund us. We got as far as interview, but I guess the boring stuff wasn't quite interesting enough for them. So we're looking for funding, actually, to take forward this whole idea of the boring things of infrastructure, and I'm just when I stop this webinar, I should be filling out another grant application and sending it off to someone else.
Stuff is in the boring stuff, so she's going to be delighted with your presentation today. Another question here from Fran Butler, who's saying that some of the GPs that she used to work with were of the opinion that video conferencing rarely added much compared to a phone call, And then often you get far more technical problems with video conferencing than you do with a phone call, so then you get productivity loss for GPs. She's wondering whether or not you think video conferencing is now sufficiently problem-free for the end user at the moment.
Well, that's an interesting question. I think certainly what we found, and our Scottish work, our work in England and some work in Australia, Canada, all showing the same thing, is that the technologies have improved massively. So it's exactly the same story with assisted living technologies, pendant alarms, all the rest of it, telehealth, telecare. The technologies are getting better all the time, cheaper, more dependable. Having said that, I think some of those GPs are probably right in that why, if you're just giving someone their blood test results, for example, do you need a video call when everyone's got a phone, or almost everyone's got a phone, and it would be so much easier just to call them up? I totally agree with that. On the other hand, I was up in Scotland last week and observing, for example, a highly skilled respiratory specialist nurse checking someone's inhaler technique through a very high-quality video connection. And this was a gentleman who lived 2.5 hours worth of driving away. He wasn't well enough to, he said he could drive his car to the hospital, but he didn't have enough puff to actually walk into the clinic because he'd got respiratory failure. But actually he had a very good consultation where she confirmed that he was using his inhaler properly, and you couldn't do that over the phone. So it's horses for courses, and I think we are now at a stage with particularly the video technology where all sorts of very interesting potential changes could be made to remote services, because you're effectively bringing the eyes and ears of the specialist much closer to the patient in the remote area.
Great, thank you. And Chris, who is a GP, your persistence has paid off. You're asking for me to ask, Trish, it may be that the data quality of the primary care records are not very good, and that's one of the reasons why patients can't get access to their records. What do you think about that? And more specifically, what do you think can be done in Scotland to improve this data quality at a national level?
Well, that's quite interesting. I'm not sure I would do it at a national level. I was very fortunate a few years ago to work in Tower Hamlets with a chap called John Robson. I think he's Professor Robson now. He was at the time a reader at Queen Mary in the department I worked, and he had been working with Tower Hamlets GPs. It wasn't just him, but he was part of a group who had worked on the quality of electronic records across all the GPs in Tower Hamlets, which covers a population of about 1 million, so a fair size. And guess what? Some of the practices were very good with their data quality. Other practices, it hadn't been a priority. And for example, some patients had been listed as having had 5 hysterectomies or other things that were pretty much anatomically impossible. And people had multiple records, all that kind of thing. And so this is pretty slow stuff to sort out, and it took probably 10 years of painstaking work with GP practices to get to a stage where you could say that entire borough, the whole of Tower Hamlets, we have high quality data, sufficiently high quality to use individual patient data in a predictive way to start planning public health interventions, for example. And I then worked with various others who were doing precisely that, could draw maps of, for example, diabetes risk. We had a project doing diabetes risk based on individual patient data. But if you did that with GP records where the data quality was very poor, incomplete, for example, or duplicated, then you're just not going to, it's garbage in, garbage out. So I wouldn't do it at a national level. I'd do it ground up. from local groups who want to use that data for local public health planning and commissioning and that kind of thing. Having said that, you've only got 5 or 6 million people in Scotland, so you may be able to do it at a national level, but I think in the end it's about motivating those on the ground to care about the quality of the data and actually resourcing their intensive efforts.
Thank you. Final question that we've got time for today from David Gorell from My Way Digital Health. I think it's a question that lots of folk will be interested in the answer to. If you're about to implement a new digital platform, what are your top tips to guide the team on a pathway to success?
Well, I would say keep it simple. I publish a lot around the NAS framework, which I haven't been telling you about today, which is really a way of getting your head around all the complexities in a project. And basically, the more complex a project, the more things are going to go wrong. So, simplify the technology, but also simplify the use case. Perhaps think of a particular group of people for which this is going to be particularly helpful, rather than try to change everybody all at once. I think demonstration projects help, get something up and running, get people to come along and see proof of concept, but then resourcing the work that has to be done to get people in the organisation to understand the technology, to share a vision for its potential, and also to learn to use it, learn to get the kind of data they need to evaluate it. All those things really important.
Thank you. Great top tips there. And that's been a fantastic session. We so appreciate the time you've taken out to share with us. You can probably tell by the quality of the questions there. Our chat box has been very active, and there's been an awful lot of interest in this highly relevant area. So thank you so much, Tricia, for that.
Well, thanks everyone for dialing in on your busy Tuesday.
and this will be available online for people to watch back afterwards, and also the slides will be available as well. Just before we finish up, opportunity to highlight that next time we're going to be joined by Sir Harry Burns, who is the former Chief Medical Officer for Scotland and is the Professor of Global Public Health at the University of Strathclyde. Sir Harry is an inspirational and thought-provoking speaker who never fails to leave audiences both challenged and motivated. So do join us on the 26th of March for that session. And just to remind you of our future speakers for the rest of the year, we've got a fantastic lineup for 2020. Tricia has set us off so well today. And then, as you can see, we've got a whole range of excellent speakers coming up. So hopefully you'll be joining us for all of those sessions. In the interim, do keep connected to us on Twitter. And all that's left is for me to say thank you for joining us and hope the rest of your day goes well. Thank you.